Lower extremity kinetic kinematic chain integration techniques, compensated postures and movements in terms of to produce a functional shortening of the lower limb. The most common example is the knee flexion moment. If flexion moment is more, that means the lower limb is going for a shortening, and extension moment is more means functionally the lower limb is going for a lengthening. Shortening from distal to proximal, when we come, what all can produce the shortening? I stand normally like this, knee does not flex, but if I do ankle plantar flexion, definitely it produces knee flexion to compensate. Okay. At the same way, if the ankle wants to compensate by producing a knee flexion, excessive movement of knee flexion, then plantar flexors will become more active, more plantar flexion movement will happen in order to produce a knee flexion. So it will cause the shortening. At the same time, if the plantar flexors are overactive also in patients, it will definitely produce the excessive knee flexion movement, okay, as a compensation. After that, for the hip influence on the knee flexion, obviously knee flexion shortens the limb, direct effect. Okay. The next one, hip. If you extend the hip, you will find foot is normal. I am extending the hip, knee is flexing. I am flexing the hip, knee is extending. Okay. So that way, hip extension is a compensation for the knee flexion. Okay. In patients who do not have much knee flexion, they will try to have excessive hip extension also, and people will produce more hip extension in order to create a knee flexion movement also. Okay. And then next we see for pelvis. If you see for pelvis, hip hiking is the lifting of the pelvis and hitching is the lowering of the pelvis. So when you are seeing for lowering of the pelvis, hitching will create a knee flexion, shortening of the limb, whereas hiking creates the lengthening of the limb. And after that, coming to the trunk. So when you are seeing for trunk rotation, if I am rotating to my right side extends, left flexes. So if I want to produce right knee flexion moment, the trunk has to rotate to left. That means contralateral rotation will produce the knee flexion movements. At the same way, for lateral flexions, it's ipsilateral. That means you are going to do a same side lateral flexion, it will flex the knee, it will increase the flexion moment in the knee. So excessive same side lateral flexion will create a functional shortening, or it may be because of the functional shortening of the lower limb. So this is a compensation. Compensation means one segment the flexion is not happening in the knee, then the trunk will try to do more, and in that bargain becoming symptomatic. For example, the symptom can be in the low back because of the lateral flexion being excessive, or patient has symptom of patellofemoral pain syndrome because of excessive flexion moment. But when you are assessing, you are finding that same side lateral flexion is more. Okay, that means the trunk has to be treated. The lateral flexors, the quadratus lumborum can be tight, or latissimus dorsi can be tight. Okay, so those muscles have to be released, and the opposite side has to be strengthened. Okay, but more important than that is to activate the core stability, because you activate the stabilizers first, then you correct the mobilizers balance. Okay, whichever is tight and whichever is weak, to strengthen that. And this is a compensatory one. This compensated postures and movements can be best understood if you are seeing what is called as the correlated postures also. One type of kinetic chain which will cause shortening of the lower limb functionally, which is a correlated posture, starting from the distal, that is the hallux valgus, the great toe adduction, excessive adduction towards the second toe, and this hallux valgus accompanied by forefoot adduction or abduction. When you see abduction and adduction, you see abduction is again the correlated posture. Okay, so great toe adduction and then forefoot abduction, which will flatten the arch. Calcaneal eversion, okay, calcaneal eversion or lateral border of the foot, okay, up and then medially weight bearing. Calcaneal eversion is also a correlated posture, and together with that you see tibia rotating internally is also a correlated posture. Internal rotation of the tibia unlocking the knee, creating a flexion moment is also a correlated posture, causes the shortening, and this flexion moment also alters the Q angle, the quadriceps angle, it increases. That is also a correlated posture alignment. After that, you see that hip going into adduction, okay, hip going into internal rotation and hip going into flexion, okay. All these are again as a correlated posture. And then the pelvis tilt, ASIS to the PSIS. If I am doing an anterior tilt, okay, anterior tilt is also a correlated posture which can accompany all these abnormal alignments right from the foot. And then next one, you can have abnormalities with the trunk also. So the trunk also can try to accompany the knee flexion by excessively laterally flexing also. So how it will laterally flex? When you have an anterior tilt, okay, that means the pelvis is hitched, pelvis is down, okay, and then because the pelvis is, which was like this, has become like this, the pelvis has become like this. So the lateral flexion has happened to the opposite side. That is also another correlated posture. And then the next one, when the lateral flexion happens towards the opposite side, the rotation happens towards the same side. So that is again as a correlated posture. So from distal to proximal, when all this happens in sequence, it is the correlated posture. But if a patient presents with an everted foot, calcaneum, but having hyperextended knee, you will know it is opposite to the what is the correlated. So knee hyperextension is present, but calcaneum is everted. You are suspecting that knee flexion has to be there if it is correlated means, but this is actually compensated. Okay, when it is opposite, it is a compensated posture. Remember, correlated also can lead to symptoms, compensation also can lead to symptoms. Patient can present with the correlation leading to symptoms means everything is going abnormal, 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 and the vulnerable segment is becoming symptomatic. There what we will try to do is, we will try to correct everything. Okay, we will try to correct it in the correlated one. That means if one student is not answering, everybody is not answering, and the other one is sleeping. That means you will definitely rectify that by addressing everybody. You have to correct it. Compensation is when one is not answering, other tries to answer, okay, in order to keep the balance right. But during that, always we find that one only is answering, the other one is not at all answering. That means it is overcompensation. Okay. So in that time, for example, if hyperextension of the knee is present with the eversion of the calcaneum, that means if the knee is getting symptomatic, we know that the compensation has become too much, so that is why it is becoming symptomatic. Or compensation it is trying to do but it is not happening, then also it will become symptomatic. Okay. So two reasons why the compensation will lead to symptoms is undercompensation or overcompensation. Okay. So when even the calcaneal eversion can change from non-weight bearing to weight bearing. In the non-weight bearing, the calcaneum can be inverted. In the weight bearing, the calcaneum goes for eversion, which is called as compensation. But this compensation can be sometimes in some people it will evert more on the symptom side. That means it is overcompensating. In other people, the eversion will be less. Other side will happen normally. The affected side will be less. That means it is undercompensated. rear foot. Okay, the calcaneum. So in such patients, what we will do for compensation is we will not try to correct the abnormality. We will just try to support the compensation. Okay. The idea behind orthotic management also, if it is correlated abnormality, we will try to correct the alignment with orthotic supports. But if it is compensated one is opposite to another, trying to adjust. In that bargain, under compensation or over compensation, we just support the segments with muscle control. Okay, that will be the best management for patients who are having compensation and then symptoms. Okay, for orthotics like insoles which are having medial arch support or lateral arch support will be preferred for patients who are having correlated postures, because we are going to correct it. We don't need a medial wedge or a lateral wedge. We just give an insole to support the foot and give the exercises for the patients for neuromuscular control. It will be a compensation type of a problem with the lower extremity symptoms. So that's the decision making implications of compensated chains versus the correlated chains. It can be kinetic or kinematic. The moment we are discussing about muscle activity, it becomes kinetic. If I am telling hamstring is overactive and quadriceps is underactive, knee flexion moment is coming more, it's a kinetic problem. If the posterior glide of the tibia is more, anterior glide is restricted, that means extension is not happening, anterior glide, so flexion moment is more. Or patella is lower, which is creating a flexion moment. Okay, then also we will talk it as kinematic problems. Okay, it's not because of the muscle action, it's because of the joint movements. So for kinematic problem, the patient requires joint mobilizations, okay, to restore the joint first. For kinetic dysfunctions, we require the muscle training, the neuromuscular training. Our priority of management goes to, first, we try to see for kinematic problems. We correct the kinematic problem with mobilizations. If kinematic is excessive, hypermobility. There also muscle control training is important. After that, stabilizers activation. We have stabilizers like transverse abdominis, multifidus and posterior fibers of internal oblique, gluteus medius minimus, vastus medialis obliquus, and we have soleus, and then we have the intrinsic foot muscles and abductor hallucis brevis. Okay. For hallux valgus, it's the abductor hallucis brevis. If that muscle is weak, the great toe goes into hallux valgus. The same way, if you see for muscles like you have this popliteus being tight, it will produce internal rotation of the tibia, unlocking muscle. Okay, so we need to see that the internal rotation is more because of popliteus tightness. We have to stretch the popliteus muscle, release the muscle. But if the same one is an external rotation being restricted, we'll give a mobilizations. Okay. So kinematic assessment will include mobility, joint play assessment techniques. Kinetic assessments will lead to myofascial assessments, and then subsequently we'll give a myofascial release or muscle energy techniques to lengthen the soft tissues. But the implications of the integration technique, LEKCIT, is when you are doing even a hamstring stretch or you are doing an intrinsic muscle strengthening for the plantar fasciitis, the patient is picking the pebbles with the toes and then putting it on another tray, core activation should be there. If the lumbar spine was the cause for the heel pain. And the same way, if the hip was the cause for that heel pain, that means gluteal activation should be there. With the gluteal activation, the patient has to do the picking up the pebbles and putting it on the other tray. And even if a static quadriceps somebody is performing, the patient has to perform the transverse abdominis together with the static quadriceps. That means transverse abdominis has to be activated first, then the quadriceps is activated, then relaxed, quadriceps is activated, relaxed. Throughout this should be active. The load of contraction what you will give for the other region muscles is only 10% of the maximum voluntary isometric contraction. That way the endurance training is emphasized. Functionally, the order of recruitment also, we have first always the activation of the core, then hip, then knee, then ankle, proximal to distal activation. And incorporating of diagonal patterns all form the basis of treatment. Okay, so that functionally three-dimensional plane is incorporated, okay, in the treatment techniques.